to switch on my video. We have these webinars on a weekly basis, and we host a variety of speakers from both practicing clinicians and also academics. And this is a CPD accredited webinar that we have. And so we request that during the duration of the presentation that you switch off your video, switch off your mute yourself. I will be presenting. So this evening is one of those evenings that we are excited and glad to have Dr. Nadiya Frank, who's joining us.
Kamo, hi. Sorry, I'm not sure if Dr. Billa is still talking. I lost him a while back.
So somebody muted me.
Oh, okay. Sorry.
Can you hear me now?
Yes, I can hear you now.
Yeah, please, go ahead, Dr. Frank, and speak to us on the obesity and its implications for mother and baby. Thank you.
Thank you very much. Good evening, everyone, and thank you to the organizing committee for the invitation and opportunity to address you tonight. Obesity is the most common medical condition in women of reproductive age, and maternal obesity has significant short and long-term consequences for the mother, the fetus, and the pregnancy. And this also raises the question, what are the implications of maternal obesity for healthcare workers? The World Health Organization defines overweight or obesity as abnormal or excessive fat accumulation that presents a risk to health. Body mass index, or BMI, is an approximate measure of total body fat and is calculated in weight in kilograms over height in meters squared. Obesity is defined as a BMI of more than 30 and is further classified into class 1, class 2, and class 3 obesity as shown. However, it is important to be aware of the pitfalls associated with the use of BMI as a measure to estimate body fat. Most importantly, BMI is unable to distinguish between muscle and fat mass. And so two individuals with very different body compositions can have a similar BMI. BMI can both over and underestimate the amount of body fat. The amount of body fat is overestimated in pregnant women due to water retention, in very short individuals less than 150 centimeters, bodybuilders, and high-performance athletes who have increased muscle mass. BMI, conversely, may underestimate the amount of body fat in the elderly, in those with muscle wasting or disabilities, and in very tall individuals. Despite these limitations, BMI is a simple measure to calculate and remains the most common tool to identify BMI at a population level. The distribution of adiposity, rather than the amount of adipose tissue, is a more accurate predictor of adverse health outcomes. Because BMI does not give an accurate indication of abdominal adiposity, which is associated with increased cardiovascular risk, the waist-to-hip ratio has become an important predictor of cardiovascular complications. The waist-to-hip ratio is calculated by dividing the measurement in centimeters at the narrowest part of the waist by the measurement in centimeters at the widest part of the hip. The World Health Organization defines a healthy waist to hip ratio as less than 0.85 for women and 0.90 for men. Because of the amount of visceral fat is closely linked to the risk of chronic diseases, the higher the waist to hip ratio, the greater the risk of hypertension, diabetes, dyslipidemia, and coronary artery disease. The mid-upper arm circumference has been used for many years to detect malnutrition in children who are less than 5 years of age. And there has been interest in the use of mid-upper arm circumference measurement to assess nutritional status in pregnancy. This is calculated by determining the midpoint of the upper arm by asking the patient to flex the elbow and identify the midpoint between the olecranon of the elbow and the acromion of the shoulder. Then asking the patient to put the arm at the side and measure the circumference of the arm in centimeters at the midpoint. A study was conducted in Cape Town in 2017 by Fakir et al. And determined that mid-upper arm circumference has a good correlation with BMI in pregnancy. A mid-upper arm circumference less than 22 is indicative of malnutrition, and a measurement of more than 32 centimeters suggests obesity. The advantage of a mid-upper arm circumference in pregnancy is that it is a simpler calculation than BMI, and its use is well suited to a low resource setting, as no equipment other than a tape measure is required. According to a national health survey conducted between 2007 and 2012, the global prevalence of obesity has nearly doubled in the past 3 decades. At the time of this publication, there were approximately 43 million children under the age of 5 that were overweight. 11% of adult males and 18% of adult females were obese, and almost a third of pregnant women are overweight or obese. A study was conducted to estimate the global burden of obesity in pregnancy for the year 2014. Using publicly accessible country-level data collected from the World Health Organization, the World Bank, and the World Food and Agricultural Association. Both upper middle income and lower middle income countries, such as South Africa, contributed significantly to the global burden of obesity. Countries classified as low income and high income have lower rates of obesity, presumably due to the lack of food security in low-income countries and better education or healthy eating habits in high-income countries. South Africa is regarded as one of the top 20 high-burden obesity countries in the world and contributes about 2.2% to the global burden of obese pregnant women. There has also been an 18% increase in the rate of obese pregnant women over the past 10 years. According to a recent survey by the Healthy Living Alliance, South Africa is the country with the highest rate of obesity in sub-Saharan Africa. What are the drivers of obesity? Obesity is a multifactorial disorder, and risk factors include a genetic predisposition, poor eating habits, a so-called Western diet, a sedentary lifestyle, pregnancy, possible underlying medical conditions, or the use of certain medications. Adipose tissue releases proteins with endocrine functions known as adipokines. Leptin, adiponectin, resistin, and ghrelin are the most commonly studied adipokines, and these are directly or indirectly involved in inflammation, immunity, insulin sensitivity, glucose homeostasis, lipid metabolism, blood pressure regulation, as well as appetite and energy balance. These effects can increase the risks of hypertension, diabetes, dyslipidemia, endothelial dysfunction, and cardiovascular disease. In addition to the physiological changes that occur in all pregnant women, pre-pregnancy maternal obesity can have an added impact on almost all maternal organ systems, increasing the risk for complications during and after pregnancy. Adipose tissue is metabolically active, increasing oxygen and cardiovascular demands, putting an additional strain on the cardiovascular system. Obese women have increased nasal, tracheal, and laryngeal edema, together with a short neck or pendulous breasts, increase the risk of a difficult airway. Pulmonary mechanics in obese women are altered. The increased oxygen consumption and reduced chest wall compliance increase the risk of hypoxia and a reduced respiratory reserve. Obesity is associated with systemic inflammation, which is linked to the pathophysiology of both diabetes and preeclampsia, increasing the risk for adverse pregnancy outcomes. The increased abdominal wall pressure of obesity increases the risk of gastroesophageal reflux disease. Obesity potentiates the hypercoagulable state of pregnancy, increasing the risk for venous thromboembolic disease. And placental changes linked to obesity include overgrowth and a hypoxic stress, which may contribute to preeclampsia and intrauterine growth restriction. The average weight gain in pregnancy is about 10 to 12.5 kilograms, distributed amongst maternal and fetal tissue as shown in the picture on the left. The Institute of Medicine first released recommendations on maternal weight gain in pregnancy in 2009, based on pre-pregnancy BMI, and the lower the BMI, the higher the recommended weight gain in pregnancy. These recommendations were informed by data at the time that about 20 to 30% of pregnant women were underweight, and that the rate of maternal obesity was only about 12%. This guideline was aimed at preventing small for gestational age fetuses, which was a growing concern at the time. In the years that followed, there were increasing rates of maternal obesity, hypertension, diabetes, and cesarean section. And this prompted the Institute of Medicine to relook at the guidelines, and they published new recommendations in 2009. However, the new guidelines were not significantly different, despite studies to suggest that a lower weight gain in pregnancy than that recommended may actually be associated with improved outcomes, particularly in obese or overweight women. The IOM subsequently published a commentary stating that their aim was to avoid small for gestational age fetuses, and that there is insufficient evidence to provide recommendations on weight gain in pregnancy for women with a BMI of over 35. Furthermore, they caution against weight loss during pregnancy due to the risk of maternal ketonemia. So as it stands, although imperfect, the IOM guidelines remain the only published recommendations on maternal weight gain in pregnancy. But does gestational weight gain really matter? In studies published subsequent to the IOM guidelines, it was found that more than 40% of normal weight, 60% of overweight, and more than 40% of obese women gain more than the IOM recommendations. An absolute weight gain of more than 15 kgs in pregnancy increases the risk of being overweight twofold and obese fourfold 20 years after the pregnancy. Increased weight gain in pregnancy makes it difficult to lose weight postpartum, which means that the woman enters each subsequent pregnancy with a higher BMI. This increases her risk for metabolic consequences both during pregnancy, such as preeclampsia and diabetes, as well as her long-term risk for cardiovascular disease. What are the implications of obesity in women of reproductive age? Obesity is associated with an increased risk of subfertility due to various mechanisms. there's an increased risk of hypothalamic dysfunction, resulting in menstrual irregularities and anovulation. Adipokines contribute to a state of hyperinsulinemia and insulin resistance. And furthermore, there's an increased risk of follicular atresia and apoptosis in obese women. The association between obesity and ovulation, polycystic ovarian syndrome, and resultant infertility is well recognized. And the rate of conception is inversely proportional to maternal BMI in obese women. All forms of infertility treatment are less successful in obese women versus women with normal BMI. What are the maternal risks of obesity in pregnancy? A systematic review published in 2018 aimed to address this question. If you look at the adjusted odds ratios, you will see that the study showed that all medical conditions, particularly diabetes, hypertensive disorders of pregnancy, and venous thromboembolic events were increased in obese women. A 10% increase in pre-gravid BMI increases the relative risk of gestational diabetes and hypertension by approximately 10%. This is very significant in our population, given that hypertension and medical disorders of pregnancy are among the leading causes of maternal morbidity and mortality in our population. Obesity also increases the risk of all organ system morbidity, maternal sepsis, and ICU admission. There's also an increased risk of cesarean section among obese women, which may be due to associated underlying medical disorders which necessitate delivery, a failed induction of labor, or difficulty in monitoring the fetus in labor, which leads to delivery by cesarean section. Cesarean delivery in an obese woman is more technically challenging to perform and poses additional risks, both from an anesthetic and surgical perspective. In addition to the aforementioned complications, another systematic review published in 2015 by Marchi et al. Highlighted two other very important complications of maternal obesity in pregnancy. The first was an increased risk of maternal mental health disorders among obese women, including depression, anxiety, and eating disorders. It is important to be aware of this, as mental health disorders in pregnancy are often given less attention than other medical disorders. However, they may also be associated with significant maternal and perinatal morbidity and mortality. The second is an increased rate of preterm birth among obese women. A woman with a BMI of more than 35 has a 33% increased risk of preterm birth versus a woman with a normal BMI. And preterm birth in the obese population is mainly iatrogenic due to associated medical conditions and is associated with significant neonatal complications. What are the fetal implications of maternal obesity? Obesity increases the risk of spontaneous pregnancy loss less than 20 weeks of gestation. And several studies have shown that maternal obesity is an independent risk factor for fetal stillbirth. Obese women with or without diabetes are at risk of having a macrosomic fetus, defined in this review as a birth weight of more than 4.5 kgs. The macrosomic fetus is at increased risk of a difficult delivery, shoulder dystocia, and birth asphyxia. Birth of a macrosomic fetus is also associated with maternal traumatic delivery and postpartum hemorrhage. Maternal obesity has also been found to be an independent risk factor for fetal congenital malformations. Whilst any fetal organ system may be affected, this review found anomalies of the central nervous system, including neural tube defects and cardiovascular anomalies, as well as orofacial clefts, to be among the anomalies more commonly detected. There are several theories as to why maternal obesity is associated with an increased risk of fetal congenital anomalies. These include maternal nutritional deficiencies. Obese women tend to have a calorie-rich but nutritionally poor diet, and deficiency of folic acid in particular is a risk factor for neural tube defects. Glycemic dysregulation, hyperinsulinemia, and insulin resistance can lead to oxidative stress and endothelial dysfunction, all of which have an adverse effect on fetal vascular circulation. There's also a suggestion that maternal adipokines may be transferred to the fetus across the placenta, creating a chronic inflammatory and hypoxic state, which may interfere with essential steps during fetal embryological development. What about our ability to detect structural anomalies in fetuses of obese women? A detailed anatomical scan should be performed on all pregnant women between 18 to 22 weeks of gestation in order to screen the fetus for both structural anomalies and aneuploidy, although an optimal fetal cardiac exam is best performed at 22 weeks gestation. The International Society of Ultrasound in Obstetrics and Gynecology, or ISIOG, recommends the 20+2 plane approach in which the fetus is divided into 7 anatomical areas with 20 specific planes and 2 overview sweeps in order to exclude structural anomalies of each anatomical area. I don't want to go into this in any great detail, as this is beyond the scope of this evening's talk, but rather I wanted to highlight that in order to comment on normality of anatomy, a detailed and structural approach is required. But how achievable is this in an obese pregnant woman? Deshay et al. Studied the effect of obesity on routine second trimester ultrasound in a cohort of over 10,000 patients, 34% of whom were overweight and 26% were obese. 10 anatomical views evaluating fetal anatomy needed to be obtained in order to classify the scan as being adequate. This group showed that as maternal BMI increased, the number of scans deemed as adequate decreased, with only 30% of women with a BMI of over 40 having an adequate scan. In particular, the fetal heart and spine were found to be the most difficult fetal anatomical structures to assess in obese mothers. A genetic sonogram refers to the assessment of soft markers at the time of second trimester scan to determine the risk of fetal aneuploidy. Similarly, Tsai et al. Showed that as maternal BMI increased, the ability to screen for aneuploidy with ultrasound decreases. The current tools available for antenatal screening for aneuploidy include ultrasound in the first trimester, that is the nuchal translucency scan, and the genetic sonogram in the second trimester, maternal biochemical screening in the first and second trimester, and more recently the use of cell-free fetal DNA. Similarly to ultrasound in the second trimester, the accuracy of ultrasound in the first trimester in obese women is reduced due to poor visualization of fetal structures. Increased maternal BMI leads to dilution of the serum analytes used for biochemical screening, which decreases the accuracy of serum screening in this population. Non-invasive prenatal testing is becoming increasingly popular to screen for aneuploidy during pregnancy. Cell-free DNA is released into the maternal circulation during cell turnover, the majority from hemopoietic cells and solid organs. Fetal cell-free DNA originates from placental trophoblasts and enters the maternal circulation following placental apoptosis. Fetal cell-free DNA contributes approximately 10% of cell-free DNA in the maternal circulation. And although detected from 5 weeks of gestation, a maternal blood draw is taken after 10 weeks. Fetal cell-free DNA can be differentiated from maternal cell-free DNA on the basis of a shorter fragment length. Prenatal testing is based on analysis of cell-free DNA in maternal plasma. Fetal fraction is the proportion of cell-free DNA which is fetal in origin, and most labs require a minimal fetal fraction of 4% in order to assess a sample as being adequate for testing. Maternal obesity impacts the fetal fraction in cell-free DNA testing. As maternal weight increases, the fetal fraction less than 4% increases from 7% at a maternal weight of 100 kgs to up to 50% in women over 160 kgs. The lower the fetal fraction, the higher the risk for so-called no-call result, in which the lab is unable to comment on the fetal risk of aneuploidy. Fetuses with a low fetal fraction have actually been found to have a higher risk of aneuploidy and therefore warrant further evaluation. So essentially, in obese women, there's an increased risk of both structural anomalies and aneuploidy, but a reduced ability to screen the fetus with all currently available methods. Obesity in pregnancy is associated with significant anesthetic implications. An excellent review on this topic was published in the Journal of Anesthesia last year. Considerations in obese women include frequently occurring comorbidities, such as diabetes, hypertension, and cardiovascular disease, which all increase anesthetic risk. The risks of a difficult airway and failed intubation are amplified in the obese gravida. Increased intra-abdominal pressure increases the risk of gastroesophageal reflux and aspiration in these women. There can also be difficulty with regional anesthesia, requiring a general anesthetic and associated airway complications as mentioned. Technically difficult surgeries and prolonged operating times increase the risk of poor wound healing and sepsis. And there's also an increased risk of venous thromboembolism. What are the postpartum risks of obese women? The risk of postpartum hemorrhage in obese women is approximately doubled versus women with a normal BMI. This increased risk is independent of the mode of delivery and may be due to lacerations, uterine atomy, as well as a retained placenta post-delivery. The risk of venous thromboembolism is increased 5 to 10-fold versus postpartum women of a normal BMI. And this is due to a wide variety of factors such as immobility, surgery, etc. There's an increased risk of postpartum depression and mental health disorders in obese women. And a systematic review on the impact of maternal obesity on lactation showed that maternal obesity was associated with a reduced intention to breastfeed, a shorter duration of breastfeeding, an increased perception that milk supply is inadequate, as well as a reduced transfer of milk to the fetus. All of these factors contribute to the reduced success rates of breastfeeding among obese women. Maternal obesity is associated with lifelong risk to the mother, and virtually every organ system is affected as depicted in the diagram. In particular, the risk of diabetes, hypertension, dyslipidemia, and the metabolic syndrome are increased. And this significantly increases the risk of cardiovascular morbidity and mortality for the obese woman. Other important complications are asthma, obstructive sleep apnea, as well as musculoskeletal complaints. How does maternal obesity influence the long-term health of the offspring? There are several mechanisms in which maternal obesity impacts on offspring health, including increased placental nutrient transfer, epigenetic modifications, influence of the maternal microbiome, which impacts on fetal and neonatal immune functioning, as well as the state of chronic inflammation. Infants of obese mothers have a higher total body fat mass and waist circumference, and this together with poor family dietary habits lead to an increased rate of childhood obesity. There are higher rates of childhood hypertension, dyslipidemia, and insulin resistance, increasing the likelihood of diabetes and cardiovascular disease. Obese children are likely to become obese adults and obese pregnant women themselves, thus perpetuating the cycle of obesity. The rising global burden of asthma and allergic disease, together with the epidemic of obesity, has led investigators to question if there is a possible link between these two conditions. A meta-analysis performed in over 100,000 maternal and child pairs found that maternal obesity is associated with an increased risk of childhood asthma in the offspring. And furthermore, a study in obese children showed that childhood obesity is responsible for 25% of new asthma cases and a higher risk of asthma versus age-matched children that have a normal BMI. Maternal obesity also adversely affects the functioning of cells of the innate and adaptive immune system, thereby increasing the susceptibility to infection. The obese pregnant woman is at increased risk of severe viral infections during pregnancy, including cytomegalovirus, toxoplasmosis, rubella, etc., all of which may be associated with severe and lifelong consequences for the offspring. Neonatal obesity is associated with impaired development of the newborn immune system and an increased susceptibility to illness and infection. Several studies have suggested that offspring of obese women may have a higher risk of adverse neurological outcomes. This includes poorer cognitive function, learning difficulties, poor school performance, behavioral problems, and an increased risk of ADHD and autism spectrum disorder. Potential pathways include a high level of nutrients such as fatty acids and glucose, a high level of hormones like leptin and insulin, and increased inflammatory mediators such as tumor necrosis factor. All of these factors affect neuroendocrine development, have an impact on neuronal proliferation and brain development. So given all the potential maternal and fetal complications of maternal obesity in pregnancy and beyond, how do we manage obese women during pregnancy? Optimal management begins with a preconception visit, which is the single most important healthcare visit when viewed in the context of its effect on pregnancy. In addition to routine aspects of preconception care, the following are particularly important in obese women. In order to avoid an unplanned pregnancy in this high-risk group, there must be a discussion on appropriate methods of contraception. Generally, estrogen-containing contraception is avoided due to the associated hypertension and risk of venous thromboembolism. Progesterone-only or non-hormonal methods are acceptable. One then needs to perform a baseline assessment for the patient, and this would include documentation of maternal weight, body mass index, waist to hip ratio, and mid-upper arm circumference. It is important to screen for various disorders such as cardiovascular disease by checking blood pressure, doing an ECG, a fasting lipogram, and possibly an echocardiogram if necessary. Screen for diabetes with an OGTT or an HbA1c. Screen for obstructive sleep apnea by taking a detailed history, and do thyroid function tests to exclude maternal hypothyroidism. It is also important to ask the mother about the presence of mental health disorders. The aim of screening for comorbidities is to optimize maternal condition pre-pregnancy so as to improve the maternal and fetal outcomes. And the patient should be referred as necessary. It may be necessary to consult a physician, an endocrinologist, a cardiologist, etc. The patient and her partner should be counseled on the maternal and fetal risks of obesity in pregnancy, as well as the long-term consequences of obesity for herself and the offspring. They should be advised that a reduction in weight and management of comorbidities can improve outcomes for the pregnancy as well as her long-term health. The patient should be referred to a dietitian for a healthy eating plan. It's important to encourage physical activity of at least 30 minutes, 3 to 5 times per week, and emphasize realistic weight loss targets of about 5 to 10%. The RCOG recommends preconception high-dose folic acid of 5 milligrams per day, as opposed to the normal recommended dose of 400 micrograms per day in any woman with a BMI of over 30. This is in order to decrease the risk of fetal neural tube defects. We have discussed previously that maternal obesity is associated with an increased risk of subfertility. Patients should be counseled that a modest or 10% reduction in weight loss is associated with improved conception rates. However, referral to an infertility specialist may be required in a patient in whom basic measures to achieve conception have failed. What about consideration of bariatric surgery? Obese women with a BMI of over 40 or those with a BMI of over 35 and comorbidities who have failed to lose weight following diet, physical activity, and behavior modification are candidates for bariatric surgery. There are 3 basic types of procedures performed with bariatric surgery: restrictive or banding procedures, which are most common, malabsorptive or bypass procedures, or a combination of restrictive and malabsorptive procedures. The care of a pregnant woman post-bariatric surgery is quite complicated and requires a multidisciplinary team approach in conjunction with the GIT surgeon. Pregnancy prognosis after bariatric surgery depends on the maternal BMI post-procedure and associated maternal comorbidities. An excellent review was recently published with consensus recommendations on the management of an obese woman post-bariatric surgery, and I encourage anyone with such a patient to look at these recommendations in more detail. There's rapid weight loss in the first 6 to 18 months post-surgery, and this period can be complicated by nutritional deficiencies that are detrimental to the fetus. Therefore, pregnancy in the first 12 months post-procedure is not advised. Depending on the surgical procedure performed and patient's symptoms in pregnancy, repeat procedures such as adjustment of the gastric band may be required. Supplementation of vitamins and micronutrients are required, and there's a need to monitor the nutritional status of the mother with repeat bloods taken in each trimester. It is important to screen for diabetes, to continue diet and exercise advice, and to closely monitor gestational weight gain in pregnancy. Breastfeeding should be encouraged. Management during pregnancy involves a multidisciplinary team. Any screening that wasn't done during the preconception period should be done early in pregnancy. In order to prevent complications from hypertensive disorders of pregnancy, low-dose aspirin or 150 milligrams from the first trimester should be prescribed. The woman should be screened early for diabetes, and if the OGTT is normal, a repeat OGTT should be performed after 24 weeks of gestation. Any comorbidities should be appropriately managed. There should be ongoing lifestyle modification with diet and physical exercise encouraged. Due to the increased maternal and fetal risk of obesity in pregnancy, more frequent antenatal visits, possibly every 2 to 4 weeks, may be required. A practical consideration is the use of appropriate equipment for obese women, such as a large blood pressure cuff and examination in operating beds, which are suitable for patients with an increased BMI. An anaesthetic consult should be obtained in the 3rd trimester. It is important to counsel the mother and the partner on the limitations of screening the fetus for structural anomalies and aneuploidy. Consider referral to a fetal medicine specialist for a first and second trimester ultrasound. Because of the difficulty in palpation and monitoring fetal growth clinically, growth scans should be done 4-weekly in the second trimester. Counsel the patient on possible difficulty with monitoring the fetus in labor. The timing of delivery will depend on maternal and fetal condition as well as associated comorbidities. However, iatrogenic preterm birth is common among obese women. A cesarean section should be reserved for obstetric indications. For recommendations on anesthetic management of obese women, I refer again to a recent publication. Pre-operative assessment would include assessing the patient's airway, screening for cardiovascular disease, as well as obstructive sleep apnea. Intraoperatively, it is important to use the correct size blood pressure cuff to avoid pressure injuries and to be prepared for a difficult intubation if required. Post-operatively, it is recommended to position the patient head up, to monitor for respiratory complications, to start chest physiotherapy early if needed, and venous thromboembolism prophylaxis. A cesarean section in obese women is technically difficult, and a transverse skin incision is associated with a decreased wound complication rate versus a midline incision. Existing evidence supports the use of a supraumbilical transverse incision in women with a BMI of above 45. This is because in obese women, there's a higher projection of the lower uterine segment as shown in the picture. And a supraumbilical incision allows for better exposure of the lower uterine segment, as well as easier extraction of the newborn. However, this incision may be associated with a higher rate of blood loss and longer operating times versus a standard phalansteal incision. If the subcutaneous layer is more than 2 centimeters, separate closure of this layer is recommended. In women with a BMI of over 30, skin closure with staples at the time of Caesar is associated with a higher rate of wound complications compared with subcutaneous sutures. However, in women with a BMI of over 40, current evidence does not show a difference between the two modes of skin closure. Postpartum care. In the immediate postpartum period, the risk of postpartum hemorrhage is increased, and the patient requires close observation and management with oxytocic agents. Breastfeeding is beneficial for both the mother and the infant. However, due to the difficulties with breastfeeding in this group, referral to a lactation specialist may be required. Obese women have a 5 to 10 times increased risk of venous thromboembolism versus normal weight women in the postpartum period. And in the immediate postpartum period, pneumatic compression devices may be used. Prophylactic anticoagulation can be initiated 6 hours post-normal vaginal delivery and 12 hours post-cesarean section if there is no concern on bleeding risk. The RCOG recommends a risk factor-based assessment in order to determine the duration of prophylaxis. This takes into account pre-existing obstetric and transient risk factors as shown in Table 1. The greater the number of risk factors, the longer the duration of thromboprophylaxis that is required, as shown in Table 2. Just based on a BMI of more than 40, prophylaxis would be required for at least 10 days postpartum. However, if there are additional risk factors, then prophylaxis may be required for up to 6 weeks postpartum. Obese patients are high risk for wound sepsis and should be advised on wound care, and the wound should be reviewed frequently in the postpartum period. Contraception should be discussed, and it is important to reduce postpartum gestational weight gain. So again, to emphasize lifestyle modification. Long-term surveillance of the mother and child, depending on comorbidities, is required, and the patient may require follow-up with the physician. The importance of preconception care prior to future pregnancies should also be emphasized. Although we are in the midst of the COVID pandemic, obesity is really the epidemic of our time, with a third of pregnant women being overweight or obese. And obesity in pregnancy has adverse effects for both the mother and the fetus, with short and long-term consequences for mother and child. Given the significant implications of maternal obesity, healthcare workers require an in-depth knowledge of possible maternal and fetal complications, as well as strategies to improve outcomes. Thank you for your attention, and I'm happy to take any questions. Thank you.
Thank you very much, Dr. Frank, for such a wonderful presentation. And we trust that colleagues have learned quite a lot from the discussions that emanated from the presentation this evening. So I'm going to take this moment that we ask questions, and I've not seen any questions being posted on the chat line. So if there's anyone who's got a question, please, you may pose a question, write your question on the chat line, or just unmute yourself and ask a question. Anyone with a question? And we thank you for just there's a question here, or there's just an excellent presentation. Thank you, Dr. Frank, from Dr. Bariatric. It will be unusual if we don't have any question from anyone after such a wonderful presentation that you've given. May I also indicate that this from tonight we are starting a new way of making sure that we record this on YouTube. And if it is okay with you, Dr. Frank, we would want to leave a link for colleagues that connected this evening so that they can access the presentations at their own free time for learning purposes at a later stage, if it's okay, because this is on the social media. In terms of
Yes.
Copy Act, we just want to make sure that we do not go against what you believe.
Okay, no, thank you, that's fine. Not a problem.
And sometimes one of the questions that we get is colleagues to ask for the presentation to be made available. So I don't know if that will be also possible for you to do that.
Yes, yes, sure.
Oh, okay. Are there any questions from the other colleagues who are linked? I'm sure there are questions from some of the students who might have linked in from the registrars, from Tres and Ibarra, who want to know quite much more, and also ask questions. I see that you also you linked issues around fetal medicine and obesity. I think if there are any, maybe someone who sees these patients in private in their GP rooms, how do they access assistance from you being in an academic setup if they are looking after these patients?
Okay. Well, any patient can be referred to a hospital, to Baragwanath Hospital, where we practice, through their practitioners. If they're referred to
I lost you there.
I was saying that any patient can be referred to our antenatal clinic if they are referred appropriately, even from a private practitioner. So they can be referred in that way. Alternatively, if they're referred within the private sector, they should be seen in the first and second trimester if the person performing the scan does not feel confident that they have assessed the anatomy correctly.
Okay. No, that's fine. And you indicate that you also you spoke about bariatric surgery, and how much interaction do you have with the general surgeons? As you're also showing the skills of what to do when you attend to these patients.
Okay. I personally haven't come across a patient in our setting post-bariatric surgery, but I think given the epidemic of obesity, it's definitely going to become something that's more common in the future. So generally, when we see a patient, either preconception or in the first trimester, who is at high risk, we arrange a multidisciplinary team meeting with all the necessary disciplines to plan for the pregnancy going forward. So if we weren't to involve the GIT surgeon, we would meet with them early in pregnancy and then have a meeting again early in the third trimester so that we can plan for issues around delivery.
Okay. There's a question now coming from Dr. Mulaudzi. Can you explain the risk associated with staples versus suture and clarification on what to consider when choosing between the two?
Okay. Based on the current evidence, in women who have a BMI of over 30, so the obese woman, skin closure with staples is associated with a higher rate of complications versus the standard subcutaneous sutures that would be used. But in women with a BMI of over 40, there's no evidence to show that there's a difference between the two modes of closure. So I think between 30 and 40 is a bit of a gray area. If you are going to use staples, then I think closely monitor for wound infection. Above 40, there doesn't seem to be evidence to suggest that one is superior versus the other. So I think, again, it would depend on what you have available to use.
Okay. Okay. I don't see any other question that is being asked furthermore. Perhaps I should just take this moment to thank you, Dr. Frank, for making yourself available for this session this evening. And also, we apologize for the glitches that we had at the beginning because we're trying to show one of the hospitals. But just want gratitude for Adam for making sure that you do come and do this presentation this evening for Clinics Health Group. And so I just want to say on behalf of Clinics Health Group, we just want to say thank you for this opportunity to share your knowledge and experience in management of obesity in pregnancy. And also, we know that you're also a fetal medicine specialist, and we hope that in the near future, we'll also ask you to come and do another presentation on this important subject, dealing with also issues of infertility. But also to thank everyone who joined us this evening. It's been a great pleasure to have you and to those who joined us for the first time. Thank you very much for joining us here on this clinic's webinar platform. And also our regulars, thank you very much for joining us and being with us at this presentation. And also to thank our team for marketing who work very tirelessly to make sure that we have these presentations every week and make sure that we get connected with all the participants who log in at every opportunity that we have for making these presentations. And we hope to welcome you again next week as we continue with our webinars, and may you have a good evening. Thank you very much.
Thank you, Dr. Bala.
Thank you.
Good night.
Good night.